Good evening, everyone. This is Veronica Sedaris, and I am the founder of Lymphie Strong. Today, I have a special guest with me, and that's Dr. Shelley DiCecco. We're going to discuss lymphedema and the pelvic floor, everything you wanted to know and more. Dr. DiCecco is a expert in her field when it comes to genital lymphedema, all things down south. We've had her speak to the group before. She's actually very excellent. She's an excellent speaker, and her credentials are extensive. So I won't even try to name them all. She's the owner of Lymphedema, which is an actual training. She trains other people, other clinicians in the lymphedema world. And most recently, I saw her at the NLN in Boston here in 2021. So I got to be a model for her during the genital lymphedema lab, and that was really fun because, seeing old friends and everyone in the community is so much fun. But without further ado, we're going to get started, and thank you so much for joining us this evening. Dr. DiCecco, take it away.
Thank you. I thank all of you for joining us tonight. I was afraid when we set the date for this that due to the holidays coming up that no one would be joining us. So we are more than thrilled that all of you decided to give up your evening, morning, afternoon, depending on where you are. So I am Dr. Shelley DiCecco. I am a physical therapist by trade. I have been a lymphedema therapist almost 21 years. And then I became a certified instructor in Shelley Smith in 2016. As a physical therapist, I had two specialties. I had lymphedema and I actually do pelvic floor therapy. So it kind of just happened that I combined the two and became a specialist in genital lymphedema. So this talk is going to kind of cover genital lymphedema and also pelvic floor things and hygiene and sexuality and everything else. So it kind of covers the gamut, and hopefully at the end there will be time to answer all of your questions. So come on, there it goes. There's my disclaimers. I am the owner and one of the presenters for Lymphed, and I'm also a professor or assistant professor at a medical school. And then I also still treat patients in my spare time. So first, to kind of get everyone on the same page, because we have patients on this, we have clinicians on this, family members, loved ones. So I want to make sure we're all kind of in the same boat as we're going through this. So we're going to do a little bit of an anatomy review so that when I refer to different areas, you know where I'm talking about. So first we need to talk about what's called your bony pelvis or your pelvic bones. That's what's special about this set of bones versus other ones in your body is it has the most combination of muscles attached or connected to it than any other section in your body. That there are over 46 muscles that either start, stop, or go through and hook onto the bones in this region. And all of us at some point in our life have had to work with groups, whether it's for this upcoming holiday planning, who's cooking what, whether it's for school projects, work projects, whatever. When you try to get 46 people working together, you always have someone that does too much work, someone that doesn't do enough work, someone that did the wrong work, and someone that never even knew they were part of the work program. So that also happens with muscles. And so what happens in this region is you get muscles that get too short and strong. You have other muscles that are stretched out and weak. You have muscles doing jobs that's not what they're meant for. And so then they can't do what they need to do. And so it really is important for us to give these muscles credit and make sure that as we're having dysfunctions and trying to treat them or get treatment, that we are paying recognition to all of them, that you have several muscles here listed for the trunk. So you have your core muscles, you have your back muscles, your gluteals, and your abdominals. You have your leg muscles that are attaching on. And some of the key ones that are often overlooked for pelvic dysfunction and for lymphedema are your pelvic floor muscles that attach onto the pelvis. When you look at the anatomy from the side, this is a female. You can see the bladder, the uterus, the ovaries. And obviously, since this isn't a stick figure, I did not draw this, But if you look down here where the blue lines are, you see them pointing to some red kind of little areas. Those are your pelvic floor muscles. The problem with this drawing and most anatomical drawings is they minimize the pelvic floor and blow up the organs and the other structures, when actually the pelvic floor muscles are much more significant in this region compared to the organs. And in fact, they come up almost to the top of the bladder to help support the bladder in women. And when these muscles become weak and other structures that I'll point out in a minute become lax, is when we start to see more pelvic floor problems for women. And the same thing here with men. They're a little bit more protected than females because you can see the prostate, the white kind of golf ball looking structure underneath the bladder, that as long as a male still has his prostate and it's not enlarged, then the prostate helps hold that bladder up. So the pelvic floor muscles don't have to work as hard. Their problems come in when the prostate is removed. You now have about an inch space that has nothing there. And so for males post-prostate issue, it's not getting back to normal after surgery. They actually need to hypertrophy these muscles to take up what was used to be held by the prostate. And so that's where males after prostate cancer have the most issues with incontinence and other dysfunctions, is because there's now a void that needs to be filled with the muscles. When you look at these structures from a ligament and fascia component, you can see on the male model up here is most of your fascia coming from the front or the abdominal region, and also your ligament that is holding the bladder in place. Ligaments stretch, especially over time. If you've lost the prostate and the muscles aren't up there to help support, your bladder, when it's filled with urine, has got some weight to it. And so what will happen with males is the bladder starts to shift down, and that allows incontinence, which we'll talk about in more depth, to start to occur, or bladder dysfunctions where they feel they need to go it all the time, and other problems. When you look at females, here's the same set of fascia and ligaments holding the bladder. For females, the bladder can do two aspects. It can go just straight down and cause problems, or it can go down and back and cause problems. And we'll get into the different components further down into the lecture or talk, I guess. This shows your pelvic floor from looking at from below on a female model, and then also looking at from the side on either a male or female. It's a unisex model. And so the muscles are made up of your coccygeus muscle and then your levator ani group. The function of these that have always been listed were to support the pelvic content. It's kind of like a hammock from below that supports the organ systems from above. It's your last minute sphincter, your final control for your bowel and bladder to stop you from having accidents. They aid in sexual function for both males and females. And then for females, they aid in childbirth. I challenge the medical texts and for the medical community that they really need to have another fourth or fifth function, depending on whether it's a male or a female, that they also have the role in draining the genital lymphatics and the pelvic lymphatics, because as we'll see coming up, your lymph nodes and lymph vessels of your pelvis are right there on top of those muscles. So by doing Kegels, or a pelvic floor contraction that was named after Dr. Arnold Kegel, you can increase the support of pelvic organs. You can improve your control on bowel and bladder. You can increase your sexual function. You can have children without tearing or having as many complications. And you can get better drainage in the lower trunk and to the legs and genital regions. And this is showing the lymphatics and how ingrained they are with the pelvic floor muscles. When you look at your pelvic lymph nodes, they are broken into multiple groups, and they're named off of the anatomical structures they're around. So you have your lumbar region, which starts around L1 and goes through L5. It's right along at your aorta. Then you have your common iliac lymph nodes, which follow the common iliac artery and vein as it branches off of your aorta to right and left. Then your external iliac and internal iliacs branch off your common, both right and left. Then you have your superficial inguinal nodes and your deep inguinal nodes. These right here are the ones most responsible for draining initially the genital region, the lower pelvis, and also the leg components. When you look on a real human, this is a cadaver dissection I took with my students at the school. You can see we've color coordinated using clothing tag guns, which I don't think that's what the manufacturer had in mind when he developed or she developed clothing tag guns, but we were able to count, quantify, and take pictures. And if you look from another angle, you can see how the vessels would be, because you can't see them with the naked eye. And also the nodes are laying right on top of your different pelvic floor muscles. So when you would get a contraction, it's just like for arm or leg lymphedema, when you do your contractions of your upper arm or upper leg or your thigh, you get the fluid to move. Now, when you're talking about pelvic floor dysfunctions, there's several of them, and we'll go through each of them one by one. Incontinence is the involuntary leak of bowel or bladder. That there's several risk factors as we increase in age. One is because we're not using them as much. The other is generalized weakness or other conditions that are coming on to us as we age that impact the pelvic floor region. Menopause, because you've lost estrogen, and that helps with the muscles and everything, the nutrients in the region. And so those things can diminish. Plus, usually your libido and other components will sometimes diminish with menopause. Muscle weakness, either from inactivity or not using it, or from other systemic conditions. Your surgeries for urological, gynecological, or rectal or prostate issues. If you were to go into an orthopedics office and have surgery on your knee, you will be sent for rehab post-surgery. But when you go into physicians and have surgery on your urological or your bladder, your urethra, your ovaries, your prostate, any of that, they don't send you for therapy, and they've disrupted those 46 muscles. And now your body's just going to heal the way it wants to, versus correctly healing like we do when you injure a knee, to make sure the muscle balance between your calf and your thigh are back to the normal they should be for healthy walking and functional activity. Childbirth, we don't prep women as much anymore as we used to on how to use the muscles to pass the children through the birth canal and out without putting as much strain and tearing onto the vaginal wall and muscles. So we see a lot more dysfunctions now with childbirth, plus the babies are getting much larger. So that's not helping. Obesity puts an added stress onto the organs and muscles and ligaments in the area. Your chronic obstructive pulmonary disease, they cough a lot and have trouble breathing, which changes your pressure system, causing more pressure. Diabetes has a lot to do with obesity, and then also how diabetes impacts the tissues in the area with nutrients and swelling. Smoking diminishes arterial supply to the area, so they're not getting the nutrients. Dementia, we don't realize we need to go or how to go or anything else like that, and so we end up with incontinence. If you have bowel constipation or incontinence, the muscles that support your bowel also support your bladder, and vice versa. So if you have one, you're more likely to have the other. Your spinal cord injury, stroke, multiple sclerosis, and Parkinson's have to do with the neurological component that supplies the pelvic floor. And then immobility, if you're not using these 46 muscles, they have a higher tendency to become weak and not supporting the structures. So I see it all the time on my evaluations that the intake form, patients will check they don't have incontinence. And then when I ask, you never leak urine when you laugh, you sneeze, you get up from sitting, they're like, well, yeah, but that's normal. That's not incontinence. The true definition of incontinence is the loss of any amount of urine, gas, bowel, liquid or solid. All of that is incontinence. That is not a normal condition. That if you were to be walking down the street and every fifth step you fell because your muscles in your calf are a little weak, the doctors would send you for therapy to address this, because that's not normal. So the same thing with incontinence. If you're leaking urine or bowel or gas for any reason, it's not a normal part of aging that you should have to accept, or a normal outcome of a procedure that you should have to accept without at least trying first to make sure you've done everything you can. On the flip side, constipation is a huge problem that patients and people don't realize they actually have, that an adult human should go to the bathroom for a bowel movement minimum of once a day, but usually 2 to 3 times a day, unless you're not eating, because it takes about 4 to 6 hours for what you ate to start to reach your large intestines. So if you're eating the food, it's getting down there, you should be passing it out. There are plenty of reasons why we don't always have good bowel movements, whether it's our diet, whether it's our water intake. The less water intake you have, the harder it is for stuff to move through your intestines. We have a fear of going to the bathroom in public. No one wants to poop at work or out in the mall or wherever you're at. And so we hold it. And when you hold it, it pulls fluid out of the colon, which makes it harder for you to have a bowel movement. But again, it's not normal and can be addressed and should be addressed so that you can get the bowel out, because you can have complications. And as you age, impaction or the backup of bowel is actually a serious medical condition that usually ends up in the hospital and sometimes with surgeries. Typically, women are more prone to have urinary incontinence due to the fact we don't have the prostate, and we also give birth to children, which puts more trauma in the region. That studies have shown about 20% of women under or greater than 60 in the community have it, and the number increases to 66% once you hit 85. Nursing homes, you have about 50% of both males and females have urinary and fecal incontinence. And the homebound seniors, usually about half, according to caregivers, have issues with it. Incontinence, again, is not a normal part of aging. There are 3 main types. There's more types than this, but they usually have to do with medicine, neurological conditions, and other components. The main ones that majority of the adults have, one is urge incontinence. That's where when you feel the need to go, you're going to leak. So it can also be called key indoor syndrome, so that you're rushing home, you need to go to the bathroom, you're holding it, and as soon as you get your keys out, you have a leak. Stress incontinence is where you change the pressure around your bladder, which causes it to squeeze and override the sphincters, allowing urine to escape. And this is going to be when you laugh, sneeze, cough, change positions, things like that. You overpower your bladder or the sphincters of the bladder, and you have leakage. And then mixed incontinence is you have a little bit of both. You're going to leak because you have to go, and you're going to leak because you cough or sneeze. When people have incontinence, there's a depression to it. Part of it is because of the aging component, accepting that we're aging, how it impacts us with our social isolation and relationships with our intimate partners or family or friends. There is a risk of skin breakdown and infections, especially if you also have lymphedema in the lower extremity or genitals, that your immune system will be altered in its ability to get to the area and help the skin or the wounds or infections you've developed. So having leakage in the area within lymphedema can really be something that leads to cellulitis. In the US, it is the #1 reason people are placed into nursing homes. Family members do not like taking care of elderly when they're having to change diapers, and they will place grandma, grandpa, mom, or dad into nursing homes at that time. It's actually the #1 reason for hip fractures, because either the person actually slips in their own urine and falls, or they're rushing so fast to get to the bathroom so they don't leak that they fall. And the fractures from that increases the odds also of being placed in a nursing home. When males or females have incontinence, the sexual function and drive can reduce. Often the function part goes hand in hand. The reason you have incontinence is also the reason you have impotency or other dysfunctions with intercourse or intimacy. And by reading this list, you could see how easily having these symptoms could cause a decrease in quality of life. When you look at urinary and bowel dysfunction, specifically as it relates to lipedema and lymphedema, often sometimes if someone has significant swelling into the pelvic region, they actually don't have symptoms of incontinence or constipation. And then as we are getting them to reduce with therapy, these symptoms start to come on. The patient thinks they're getting worse, that their symptoms are increasing, and they become upset about this. And sometimes the therapists don't have good explanation. But the reason is the fluid was taking up the space that the muscles have not filled. So they actually support the bladder and support the colon and hold them in place and help them with their continence. And as you reduce it, you start to see the symptoms. This is still a sign of progress because you're getting fluid out of the area, which can cause so much more harm. It just means now you really need to make sure you are addressing the pelvic floor and the other muscles that attach to the pelvis so that you can now support the structures properly so that those symptoms too start to reduce. As we talked about a second ago, you're at an increased risk of infections and skin breakdown when you have lipedema or lymphedema and bowel or bladder dysfunction. You're at the increased risk of falling, as we discussed before, because of slipping or running, but also because your body is out of shape, as in it's distorted in balance. So if one leg is larger than the other or one calf is larger than the other, it throws off your balance, which messes with your pelvis, which interferes with the muscles that support the region, which also increase your chance of falling. And there's a psychosocial impact on this as well, that you're already having to accept and move or go through with lymphedema and lipedema. And then you've added something else onto it that you have to either address, deal with, accept. And so it can double down on the psychological impact of all the conditions independently. They did do a study on 199 females in 2014 with the sling repair. The problem with the sling repair is what they're trying to do is remember back to the ligaments supporting the bladder at the beginning of the presentation. Those become stretched out. And when a ligament stretches out, it does not shrink back. So what the doctors are trying to do is take a thin material to loop around like a lasso around the bladder and pull it back up towards your abdominal wall or your pubic bone and hook it. The key is when they do this surgery, they can't use strong, hard material or it would cut into the bladder and either cause it to become ischemic where it's cutting off oxygen and blood supply or actually damage the wall. So it's again, very thin, not that strong material. So it's very common to hear that women are on their third sling repair. And what they found is women who had a higher BMI had a significant reduction in positive outcomes, that you had 87% roughly in the women with lower BMIs had success, where only 65% roughly of those with BMIs greater than 30. And about 60% of those with BMIs greater than 30 still had urge incontinence after the surgery. Prolapse, that is what happens when organ structures start to move down or backwards into the pelvic cavity. So the pictures at the front where it had the green arrows showing how the bladder for both males and females can drip down or drop down. Typically, we keep the phrase prolapse for women, but technically that is what happens to the male bladder. It's just doctors can't assess it the way you assess a female. They look through the vaginal opening and look to see, can they see the organ structure coming down into the vaginal vault to grade it. Males don't have a vagina and they don't really know how to grade it. So they don't typically call it prolapse on males, though technically in the true essence, that's what it is. For females, it's common post-childbirth surgeries. And as we've talked about with age, males, typically it's with prostate issues. If you build up this pelvic floor muscles so they're back to either their normal or increased bulk and size and strength, it will support the structures again, reducing the prolapse and the symptoms associated with it. Again, lymphedema can mask these symptoms because they provide the support. So you can have multiple types. You can have where the bladder comes down into the vaginal vault, and that's a cystocele. You can have the actual uterus, which is a uterine seal or uterine prolapse. The rectum can fall into the vaginal vault, and it's a rectocele. And if the woman has had a hysterectomy, you can have the intestines, which is an enterocele, and the vaginal vault falling down. There's different degrees on whether it's just kind of hitting into the vaginal vault or if it's all the way outside the body. The reason these are important to recognize and to understand is the next two slides are going to show you some imaging that almost every adult has always or has at least once done what's called a Valsalva, which is where you bear down to have a bowel movement. You try to push it out. And the next slides will show why that's a bad idea and what it truly is doing to your bladder and your rectum when you do a Valsalva to have a bowel movement. This first one is a bladder, and I'm going to let him talk, this physician.
Dynamic images of the pelvis. Here's the urinary bladder. Here's the vagina. Here's the sigmoid colon and rectum. Patient try to bear down, taking a Valsalva maneuver, straining, and then you see the urinary bladder go below the symphysis pubis by about 5 centimeters, 5.3 centimeters. So this bear down, the harder patient bear down, straining, the harder for the patient to defecate because of the urinary bladder is occupying the pelvic outlet. So it's harder to defecate. So this is a problem today.
So with a cystocele, you can have both urinary issues and you can have rectal issues because the bladder is taking up all the area to block it. This one here is going to show you, you'll see the dye shoot back from the rectum towards the bladder area, which is where it's having a rectocele. And so what you'll see often with the rectocele is you have smearing after you finish, you've stopped wiping, you'll have stuff show up either just onto your skin or even into underwear. And a lot of times ways to tell you have a rectocele is your bowel is no longer cylinders. Patients always get a very weird look on their face when I start asking them, what does their bowel look like? That is it a cylinder? Is it a flat ribbon? Is it more little tiny pellet balls? Because the flat ribbon and the pellets are signs of rectoceles because the rectal opening is not how it should be, or the end of the colon. I wouldn't recommend having this as your holiday discussion of asking everyone what their bowel looks like. So this will show a rectocele. And you can see how it bulges forward there. And so that bowel can't get out. With pelvic floor dysfunctions, you can also have, whoops, wrong direction. You can also have pelvic pain that I wish every gynecologist and every physician for males and females would explain to patients. Intimacy should never be painful. That if there is pain in the region, something isn't right, whether it's one of the 46 muscles, if it's the nerves or other structures in the area, but something's not how it should be, which is causing the pain, that it should never hurt to be intimate with someone. Bowel movements should not hurt, that our colon can stretch, that if you are having pain when you're having bowel movements, something is typically wrong. Either the pelvic floor muscles are in too much of a spasm, you have a fissure, which is an opening, you have something else going on. You shouldn't have a pressure or a discomfort sensation in your lower abdomen or pelvis. That is also a way your muscles and other structures let you know things aren't right. that when your hamstring or the back of your thigh has an issue, every time you walk, you would feel pain. With internal muscles and internal organs, they don't have the same nerve output. So when they send signals to your brain, it's not the same. And so often it can tell you the pain's in another region. I've had patients have rib pain when it's coming from their pelvic floor, or it can come out as pressure, like you have gas or something going on. There's just a weird pressure sensation. It can be tingling, kind of nerve symptoms going on. So there's a lot of different symptoms in that region. If you're having them, it's not a normal component. You can have pain in the vagina, the rectum, the penis, the testicles, bladder, abdomen, back or buttocks. Inner thighs is a very common one, especially more sharp pains coming into the inner thigh. Your low back and even down your leg, it's not uncommon to have a diagnosis of sciatica when it's really coming from the pelvis. The key is pain is never okay. If you have a medical professional telling you it is, it may be time to see another medical professional. There's multiple causes for pain. It can be scar tissue, that most of our structures in the pelvis needs ability to move. And if you have scar tissue blocking your intestines from being able to pass a bolus of food, like we're all going to eat, hopefully over the next few weeks, that it will stretch and cause pain. Or if you're trying to have intimate relations, or just even sitting and turning can cause pain with scar tissue. Trauma in the region, that do you have inflammation or other problems from the trauma, whether the trauma be surgery, the trauma be a bad fall, or the trauma can be some form of sexual abuse for males and for females. As we age, there's an issue with lubrication, and that can sometimes be the sole cause of pain, is that we don't produce the same amount of lubrication and the structures aren't ready. You can have skin atrophy and breakdown, that if you're not participating in some form of intimacy to get engorgement for males or females into the region, you're not getting that large bolus of blood, which brings in all the nutrients your skin and tissue need. And so you start to see more atrophy in the skin in those regions, or where they start to sag more and have loss of tissue rebounding effect. You can have abnormal muscle tone, you can have muscle weakness or muscle spasms. You can have a medical condition, so you could have Crohn's, inflammatory bowel syndrome, ulcerative colitis, prostatectomy. You can have all kinds of conditions that are causing pain to occur down there that could be addressed. And part of it can also be fear, that our body is not stupid. We don't like to feel pain. So I always use the example with my patients of the dentist, that most of us actually like the actual dentist, but most of us start getting sweaty palms. We start getting tense. I know I take Tylenol before I go in, because I know that the hygienist is going to take out all the anger she has from the woman that cut in front of her in the Starbucks line out on my teeth. So you start to get this anxiety about what is to come. Your body responds, your heart rate goes up, your blood pressure goes up, your muscles start to tense. My shoulder muscles will tense up as I get to the dentist. The same thing happens with your pelvic floor. You just don't notice it as much because you can't see it, that your muscles and everything start to tense up of, oh my goodness, this is going to hurt. I can't go through this again. And then we actually feed forward that pain loop. Because of us responding, we're more likely to have the pain and continue that cycle. So all of these symptoms can be addressed with proper treatment, and we'll get to that a little bit later. Genital lymphedema, that depending on the articles you read or the medical professionals you work with, it can be anywhere between 2 to 70% of those who have lymphedema in the legs can have genital lymphedema. Typically, the males are the ones diagnosed, that the studies will show between 10 and 40% of males will typically have it. Males can have it in the scrotum and or the penis. Females, the reason they're often undiagnosed as much is because we can have more internal involvement. You can have the entire vagina filled with fluid, and you may not see it. And if you don't know how to properly assess it, or your medical professionals don't know how to assess it, it can often be overlooked until it hits into the labias, and then your external genitalia is swollen. Another reason that both of them are underdiagnosed is because the conversation. Doctors don't know how to ask about it sometimes, and the patients don't tell the doctors and bring it up. And the same thing with therapists. Some therapists are not comfortable discussing the genital region, and the patients aren't comfortable back with it. Medical professionals don't know how to assess it all the time. Like I was saying with the vaginal component, all physicians and therapists do not know how to assess for vaginal swelling. And if they haven't been trained, they really shouldn't be doing it. The patient a lot of times does not realize they have swelling. It's rarely mentioned in books and rarely studied with research. I could spend 5 hours trying to go over compression components, and I don't have that long. That I do have to get to sleep sometime, and some of you do too. The keys with compression, though, is it has to hold when you're talking about bandages. It can't fall off every couple hours. The patient and or their support team must be able to do it multiple times a day, because often it has to be removed or altered every time they go to the bathroom. It must cover all areas involved. We don't wrap this part of the thigh, skip the knee, then wrap the calf. That you cover what's involved, or you should. So the same thing with the genital region. If the penis is swollen, the penis should be addressed. If the testicles are swollen, the scrotum aspect should be addressed. If the abdomen is swollen, it needs to be addressed. That you can't leave portions uncovered because you're just moving fluid around, then you're chasing it. Garments for both males and females need to support and lift and compress the genitals. The most important during the day is the supporting and the lift to fight gravity. Gravity is not our friend when it comes to the genitals. So you want to make sure you're combating that and keeping the genitals up and compressed. You do need compression 23 hours a day. What you wear at night can vary significantly from what you wear during the day. The nighttime compression typically is used more to reduce, and the daytime's more to support. And they're often going to need to change as soon as you figure out exactly what works for your patient or for yourself. Your structures are going to change in shape and size, and then that component is no longer going to work. So both parties need to be very flexible, understanding that this region changes more than your arms and legs do and constantly needs altering. I have no interest in any of the product companies. The only reason I usually include product names when I do talks with patients is because, unlike therapists, they're not going to be able to look at this slide and recognize where they are. And if you need to start having conversations, you need to have some background on it. But there's no product that is perfect for everyone, and there's no product that's horrible for everyone. It all fits different individuals. But this gives you an idea of all the different variety of textures and shapes and designs and sizes, because again, the entire area needs to be addressed. So these are more for males, and these are your pre-made ones for females. You can also have custom ones made from actual companies, or I love to play arts and crafts with my patients. And often before we spend money buying a company's version, we will cut something out of actual foam and try to fit it so we can make sure it's going to work for them the way we want before we buy something of this nature that's going to last longer than Shelley's Arts and Crafts. Same thing with garments. Again, I'm not trying to sell any of the products. This is just to show you the wide variety of garments that could be used, and there's more coming every day. I'm even working with some therapists to help try to come up with better peds ones. My mother's going to appreciate when I tell her at Christmas she's got to help me sew some, so we have some ideas of what will work. Haven't given that to her yet. But you have all kinds of garments that you have to be able to put it on. You have to support the structures, and you have to make sure, as you see with a lot of these, there is an abdominal and or thigh component, because you can't address just one area, and everything from your belly button down to your toes all drain through the same region. So if you have swelling in the leg, you're at risk for having swelling in the genitals and the lower trunk, and vice versa. When it comes to manual lymphatic drainage, It must be done daily, especially when genital areas are involved in lower pelvis, because again, gravity is not your friend, and you must cover every area that's involved. The patient and or their support team, and when I say support team, I mean their caregivers, if they're not able to address it themselves, must be able to do it. It needs to be done in order. You can't just decide, oh, I'm going to clean my left buttocks today and nothing else. You have to clean the way your therapist is showing you, where you were starting, more in the trunk region, then the genital region, and then the legs. You don't want to clear legs before you've cleared abdominal, back area, and genitals, because you're just bringing it to the genital region and backing things up. You do need to make sure skincare, especially in this area, because it is prone more than anything else besides maybe your feet to infections, that bacteria loves warm, moist areas, which is what your genitals are. So you have to be checking this area daily. You have to be cleaning this area daily, which we'll go over a little bit more. And if you see any changes, don't wait to see what occurs. Make sure you speak to someone, whether it's a therapist, you're a doctor, someone about it. And exercises are important. The new research shows with ICG imaging that patients should no longer lay passively during their manual lymphatic drainage, that they actually should be contracting muscles, especially near nodes and bigger vessels, to help move it out. So you shouldn't just lay there anymore. You should be doing some activities. You need to be doing exercises daily, and again, in the sequence, so that you're draining the trunk, then the genitals, then the legs, including all areas. And adding cardio components and or pelvic floor muscles are also great for helping these regions clear out. So what do we do generally for pelvic floor dysfunctions? There's a lot of medications out there that you can try for pain, for incontinence, for constipation. But the problem whenever you take medications, and I'm not saying anything's wrong with them, because a lot of my patients do very well on medication, but a lot of times there's significant side effects, and then you have to take a medication for the side effect. So if the medication works without causing other problems, then great. But if you start having significant other side effects that you have to medicate, then maybe medicine's not the route to go. Surgery, as we discussed with the slings, the problem is when you're doing surgery for pelvic pain or for incontinence and prolapse and stuff, a lot of times the surgery causes more problems or doesn't last because, again, they can't use hard structures in the area. Whereas physical therapy, and in some states occupational therapy, it depends on their practice act, can treat pelvic floor dysfunctions with no adverse side effects and no surgical recovery times. Some conditions they can treat range from the constipation, incontinence, prolapse, muscle weakness or pain from surgical procedures or cancer treatments, childbirth injuries. In France, every woman 6 weeks post-baby, so postpartum, sees a pelvic floor therapist. We don't do that here in the US and some of the other countries, but they have better outcomes because, again, it's like knee surgery. If you see someone to help with the muscles, you usually recover better. Your therapist can help with swelling, whether it's lymphedema or pregnancy-related varicosities or other components, they can be addressed. So if you have lymphedema from breast cancer, you can still have swelling in your genitals when you become pregnant that can be addressed. And then your pelvic pain has so many different diagnoses that go with it based off of where the pain is generating from or showing, or you just have certain doctors that are always going to call it a certain term, whether it truly is that or not. So what is your therapist going to address? They're going to help reduce the frequency and intensity of your leakage. They're going to decrease your constipation, hopefully, improve sexual function or intimacy, decrease pain, decrease the risk of comorbidities, and hopefully overall increase your quality of life. How does this occur? Again, we have to think of the 46 muscles. We have to strengthen what's weak. We have to stretch what is tight. There is a lot of soft tissue or massage work that is done. There's a lot of education you need to fully understand, just like with anything else, whether it's lymphedema or pelvic floor dysfunction, you need to understand what's going on. Biofeedback, if I'm working on strengthening my arm, I can look at my bicep and see myself contract it and relax it and know I did it correctly. For me, it's like flossing. I cannot floss if I am not looking in a mirror. I just can't figure out where the floss goes. You can't see your pelvic floor muscles. So this is using sensors that give you the feedback to let you know, did you or did you not do it correctly? And then if you're having trouble, because a lot of us are motor morons, and what that means is we just can't connect what we should do to what it is happening, and it just doesn't work. Like, I will never play golf. I've tried, it does not work. I am a motor moron when it comes to golf. I can't get it figured out. You can use electrical stimulation to override your ability to contract the muscles, to let you see what it feels like or get the muscles to a point where they're strong enough you could contract them on your own. Other concerns with pelvic floor is infections. If you think you have an infection, especially if you have lymphedema, you do need to see a doctor immediately. That there's so many different strands. You can become resistant if you continue to use over-the-counter treatments on your own. When you shower, don't share towels with people, and make sure you dry your feet last so that you're not bringing fungal infections from your feet to your genitals. A lot of times, whether you have swelling or just pelvic floor dysfunction, you can have itching and burning into the area. Cool water, pouring it over with a cup after you go to the bathroom or just when you have the symptoms, can help kind of calm the area down. When you can, if you can go without underwear on so that it's able to get some air to the area, because again, it is more moist in that region. If the pain or burning is significant, you can use cool packs, frozen peas, covered in a small towel so that you're not freezing the area, but to cool it down. Yogurt is a good thing to eat for pelvic components because often it's a problem with your bacterial balance. So by eating yogurt, you're bringing in live cultures that can help grow good bacteria. When you're talking about sexuality with lymphedema, there's often a decline in libido, that the desire to have intimacy, it reduces either due to the body changes that we've gone through because of the lymphedema, the impact of treatment, the cost, everything else that's put on the family, that there's a lot of different reasons why the libido starts to decrease. Hormone changes, if you had prostate issues and now you're having to take hormones, female hormones, to keep from getting prostate cancer again, your sex drive will go down. And females that have gone into menopause, libido can go down. The great thing about libido, if it goes down, it can also come back up. That by having stimulation or excitement, actually, it's kind of like eating sweets. The more you start having intimate feelings, the more they keep coming and the easier they start to arise. So trying to, even when you don't want to have something with intimacy will help bring that back up. Sometimes working with finding ways to arouse yourself versus having partners can also help with that. There can be a decrease in sexual response. A lot of this has to do with the muscle components, so that if you build up the muscles, you often will have a greater response, especially for males. There's a psychological component, and so sometimes talking it through with people that are not in the intimate relationship, whether it's your therapist, a physician, a psychologist, someone that's in the religious realm, whatever works, talking to someone about it. There's a lot of difficulty with lymphedema because it does change the body. So whether you can get in positions to be intimate like you were before, if you've had breast cancer, a lot of times having pressure on your chest is uncomfortable. So that interferes with intimacy. So there's a lot of issues that come with lymphedema and other conditions that can change. So again, ways to improve it: use it or lose it. That the more you try to engage in intimate activities, the more you start to see a return. That engorgement also brings in those nutrients from the arteries so that your muscles and tissues actually get a enrichment of the oxygen, iron, protein, the different vitamins into that region. So engorgement can be a good thing. You just need to know how to do your MLD or exercises to get it back out if you have lymphedema. Working on the psychological component, a lot of education on positions and safe ways to have intimacy, lubrication. that we'll discuss those in a minute on the next slide on what some different lubrications to use. And speaking with your doctor on whether or not you are or are not, depending on your other comorbidities, whether or not you are a candidate for creams, whether that's estrogen or testosterone. Just keep in mind, if you do use the creams, either of the hormones, you don't want your partner getting those creams on them because it can cause problems for them. Your lubricants, you are not to use Vaseline, baby oil, or Crisco. Coconut oil, I'm questionable on because I did read an article and I've yet to be able to find it again where dental researchers found where it did grow fungal infections into the mouth using coconut oil for the gums. So the original and the longest used lubricant is actually olive oil. So a lot of times I'll recommend olive oil to patients to use. If you're not, you're going to want to use something that's water-based solutions. It's kind of like when you buy stuff at the grocery store, you want to minimize the ingredients. So when you're looking at lubrications, if it has more than a handful of ingredients into it, you should stay away from it. That you don't want proteoglycans, which is like fiberglass, into it. The reason they put those into lubricants is because it adheres it to the tissues better so that it stays in place. But for those that have pelvic floor problems or lymphedema, it can become an irritant. Other irritants is when they've added things like the warming stuff or other components to lubricants. You just need basic lubricants. Males and females should always use the restroom after any form of intimacy because your urethra gets irritated by the engorgement and or friction. And so by going to the bathroom, it empties out your urethra, which reduces your chances of infections and breakdown. And you can also use cool water to pour over the area or use a wet wipe, and that decreases your chances of infection and irritation. And the cool component can also help with reducing the engorgement post. General hygiene, you should wash daily. I have to sometimes tell people that. You don't want to reuse washcloths and towels and never use a sponge. That try to use something clean in the area every time. You need to watch hot baths, drying soaps, and scrubbing because you can cause dry skin, breaks in the skin, which lead to more infections. Whenever you look at whether it's soaps, bubble baths, lotions, anything like that, the fragrance and the color components of the ingredients are not controlled by the FDA. That what was in before the actual soap or the lotion component is, but they don't look at the bubble baths, colorings, or fragrances. And so sometimes the fragrances or colors can actually be an irritant or change the soap that used to be antibacterial. Now it's not antibacterial because the fragrance made it where it is now a neutral to basic pH as opposed to acidic. So try to go with the more hypoallergenic or fragrant-free. You always should have clean hands, whether it's with soap or wearing gloves when touching any part of the genital region, because again, it's prone to infection and skin breakdown. If you're having issues, you can always rinse off and pat dry. Toilet paper, as we all have realized with COVID, one, it's not easy to always find, but not all toilet paper is the same. That I know I had to branch out from my normal brands and I did not appreciate it. That toilet paper, if it leaves residue for males or females into the rectal or vaginal area, it's again like fiberglass is an irritant. So a way to do a quick test that's not embarrassing is if you have darker color clothes on, fold or prepare your toilet paper as you would if you were going to wipe, whether you crunch it up or fold it. And then with the same amount of pressure, rub it across your pants. If the pants have white residue or the color of toilet paper, if you use colored toilet paper, is left on your pants, that's also what's left onto your rectal area or vaginal area. And that can be an irritant. So usually you're unfortunately more expensive are the ones that have more fitting, or I don't want to necessarily give names, but where it has more to hold the two plies together, usually are better. When you're talking about not for compression, but if you don't have genital lymphedema and you have pelvic issues or trying to keep your pelvic health as healthy as possible, Cotton underwear that's not too restrictive is best. Thongs are the worst things invented because it is like a party barge between the rectum, vaginal, and urethral opening for females, and the bacteria can change and move to different areas. I don't know how many times I've had patients come in with C. diff in the bladder, and the physician and them can't figure out where it came from. It came from wearing either a thong or a maxi pad, which we'll discuss on the next slide, for too long. If you can go without wearing underwear at night, I would recommend it. If you have to wear it for compression, this is where you want to have a good nighttime garment that helps with compression, but also has good airflow so you can help with hygiene. Be careful with powders in the area. Cornstarch is about the safest one. And again, watch fragrances. Cosmetic cleaning or trimming, you don't want to douche unless you are instructed by medical professionals. Shaving, waxing, lasering, plucking, dyeing, or piercing can cause inflammation and infections. That you can trim the area, but watch the others because they can cause inflammation or they can cause skin breakdown and infections. I understand that maxi pads are expensive, but a maxi pad, whether you are a male or a female, should be changed every 2 to 3 hours because, again, bacteria from the rectum can come down and move, or bacteria from the other areas can come down and move. So you want something that will pull away and change. If cost does become an issue, you can buy washable pads that can be reused over and over again. And so you're not having to spend the same amount as you would if you were throwing away a disposable pad several times a day. Tampons, if you are a female, you do need to use non-fragrance and the lowest possible absorbency that you need. And again, they should be changed every 2 hours or anytime you go to the bathroom because the infection component. And that's typically true on whether you have issues there or not. But you can also, if you're having a lot of problems with bowel movements, I have had patients insert a tampon to press back against to the rectum so they can have their bowel movement. Then you pull the tampon out and throw it or flush it down the toilet or throw it away, depending on your sewer system. There's not a lot of studies that we've discussed. So myself and my colleague, Rhiannon Noble-Jones out of Wales, who also specializes in genital lymphedema, we are doing a study. So those of you that are medical professionals, if you can take a picture of the QR code and do this later, I would greatly appreciate it because we're trying to get input from all the different countries on what the confidence level of healthcare providers are with treating genital lymphedema. And then for patients and for healthcare practitioners, 2 new resources came out this month that the International Lymphedema Framework put out the genital edema supplement that's kind of a position paper so that it can help you with different things that are being done for treatment and also to provide to your medical professionals to give them more information. And then I did do a very thorough article in the Canadians Lymphedema Pathway magazine on genital lymphedema. So at this point, I again thank you for listening, and I will stop sharing my screen so that we can answer some of these questions that y'all have come up with.
My goodness. This is what I'm talking about when it just, you know, everything that you've shared just blows my mind. I mean, I think I've heard it before when I've heard you speak, but then I'm reminded, I'm like, oh yeah, gosh, that makes so much sense when you put it that way, you know, the party barge analogy.
Yes. Yes, yeah, you can see lots of infections from that.
And can I just say that I'm so thankful from the bottom of my heart for you volunteering to come on to the YouTube channel and share, you know, your expertise and just the wealth of knowledge here. We're going to jump right into the Q&A.
Go for it.
Forum. And first question, are you aware if lymphedema affects our organs and has unseen side effects on our organs and organ damage that silently progresses?
So yes, so lymphedema can impact your organs in 2 ways, that your organs do have lymphatic drainage. We used to think the brain and the eyes did not, and we now know that those were the only two structures we didn't think have it. And we now know that there's actually lymphatics for those two structures also. So there is drainage for each of the organs that if it's blocked due to your cancer treatments or whatever else you had that causes general lymphedema, it can stop clearing those organs as it should. And then you can also have external fluid putting pressure on the organs, so that if your kidneys are trying to do their normal function and you have a lot of swelling into the abdominal cavity for other reasons, that added pressure can add strain to the kidney, whether it's the vessels, the veins and stuff coming out of it, or vessels trying to go into it. So lymphedema can impact organs in two ways, either actually in the organ or from outside sources. So it is harder to diagnose organ involvement because your ICG scans and your lymphoscintigraphy don't show it as well. They are progressing. That was one of my favorite presentations at the International Lymphedema Framework Conference this year. And you can still watch their live videos that they recorded of all of us. There is a doctor out of Philadelphia that is improving on the imaging, and he was showing what he could do with organ structures for especially primary lymphedema. And that was something that I haven't seen before in the lymphatic world. So they are improving it. The main thing is you have to be your best advocate, that you can't expect your healthcare professionals to keep up with everything, because especially with lymphedema, it touches so many different arenas in healthcare. That is it colorectal? Is it pulmonary? Is it vascular? Is it oncology? That physicians can't be expected to read every periodical that comes out. They can't be expected to go to every conference. So you need to also make sure you're actively taking a role in learning what you can from going to talks like this and other things, so that you can help bring the information to them sometimes, or know who to go see. So they are improving it. And I hope that answers your question, since I don't know exactly which organ you're talking about, but yes, it can.
And that's why, and to your point, that's why webinars like this are so important, because you can, if you don't know what to ask, then you don't know, but you sharing this information is it's just amazing. Second question, interesting about female swelling. I failed a recent gynecological exam because my swelling prevented a speculum being inserted. I'm being sent to a sedated exam. What can I do to fix this?
It's not uncommon that often that's usually the first time physicians realize there's swelling there. That you need to find a therapist in your region, preferably one that is dual trained, because CLTs are not trained to do internal vaginal assessments or rectal assessments for males, and are females. You can do rectum on both, and they shouldn't be doing if they haven't gone through pelvic floor training, because because we can't see it. For a knee, I can see what I'm palpating on your knee. I can tell, is that a muscle, a ligament, things like that. When you're talking about the internal pelvis, whether it's vaginal or rectal, we can't see what we're touching. We have to go just on feel. So if you haven't gone through training so that you know that, yeah, that's a muscle, yep, no, that shouldn't feel like that, doing it on someone with lymphedema for the first time should not be what you do. That you need to know what normal feels like, then what dysfunction feels like. So there are therapists, and if you want to email me, please feel free to email me, that I'm more than happy to help you find someone in your country or region. But you can find specialists that do know how to assess the internal component. And I remember one of my females, one of the first ones I treated, where I realized the vaginal area was swollen, she went back to her gyn-onc, and he goes, I don't know what Shelley did, and I don't mean to sound crude when I say this to you, but you now have the prettiest vagina I've ever seen. That I never realized you have lymphedema in it until I see what it looks like now. So don't just have to go where you're always sedated and think it's normal that you have to go forward with the swollen vagina, because again, it can then drop into your labias and cause other problems. Or for males, it can cause problems too. And you can go rectally and do other components, that it can be treated and should be treated.
That gives me so much hope, that that resource is there. And if you're not aware, I've done a blog post on Shelley's work here, and it's on lymphiestrong.com. All you have to do is go to a little magnifying glass and type in genital lymphedema, and she's got some handouts and her email. We'll obviously share her email after this presentation, but there's also that resource there on the lymphiestrong.com. Next question is, where can I find resources for manual lymph drainage in the genital areas, and how to evaluate my own possible lymphedema in this area? And I just want to make a note, it's not just for women, it's for men too. So yeah.
So there's not a lot of resources. That one, no one really wants a video posted. And even I, if you notice, I do not ever put pictures of patients of mine with genital lymphedema in any public forum I use. That in the individual courses where I can watch for cell phones, I will show them. But for large arenas, I never show a patient's pictures of the genitals. So like even some of my videos that I use for other therapists, my patient is fully dressed when I'm doing it. So the thing to keep in mind, without getting too in depth on the anatomy component, is your trunk, right where your pubic bone is, switches to the thigh region technically. So your genitals are actually part of your inner thigh when it comes to lymphatic drainage. So a lot of times what happens with patients, if you're not getting the clearance up the anterior trunk, it's because all of us have a fat pad there at your pubic bone. Otherwise, we would never have ridden a bicycle. We never would be involved in intimate activities. It would hurt because that's a very sharp bone as your pubic bone. So sometimes that fat pad can limit drainage of the genital region. So rarely ever do I ever use the anterior approach, which is the more common approach now. I almost always go posteriorly because your inner thigh goes all the way up your butt crack to your top of your pelvis is the inner thigh. So rarely, if you don't do it now on the camera, I can only see Veronica, but the rest of you, please don't do this where others can see you, not in Walmart or anything else like that. But if you have lymphedema and you palpate or touch your interbuttocks region, rarely is it hard. It's almost always, no matter how swollen you are, it's almost always soft. So I find I get much better drainage coming posterior, like how you wipe your behind after a bowel movement, to bring genital swelling, whether it's male or female, out the backside versus going from the front. So I'm always helpful or happy to help more with the therapist teaching in the pathways more so than patients, because with patients, I don't know, I can't see you always, and I can't tell you what to avoid if I don't have you, but I'm always happy to speak with your therapist where they can give me a better medical background and landscape that I'm dealing with on helping them find proper pathways. And then I can try to give patients some general aspects, but again, without having you as a patient I've evaluated, I can't always help with that.
Okay. Next question is, can you provide more info on biofeedback therapy?
So with biofeedback, it's a double-edged sword. It is a great way to provide additional input, but it shouldn't be used as a standalone therapy. That too often you will find where medical professionals will hook you to biofeedback, tell you to do this, and they leave you in the room. That's not the point of biofeedback. Biofeedback is when you can't isolate a contraction of your pelvic floor, or I use it a lot with also position training, especially going to the bathroom, because everyone I'm sure has heard of the squatty potty. The squatty potty does not work for everyone, but the thinking behind it does. The problem is most of us try to use a standard toilet, whether we're children or adults, and that may not be how our pelvis is meant. Or for intimacy positions, that may not be the best way for our body to relax with intimacy. So I use biofeedback to, one, help patients realize you got a contraction, good job. Once they can contract, I stop using the biofeedback because I want them to pay attention to what they're feeling and doing more so than what the machine is telling you. And they've gotten so advanced, like you can build like balloon races, car races, all kinds of stuff with biofeedback machines. Or I use it for how many books should you have under your feet, or do you need a squatty potty, or do you need to elevate the toilet seat because you're really tall, or this is not the best position for intimacy for you. You need to be in this position so that your pelvis can fully relax to stop the pain component. So it's a way for you and I to image the pelvic floor muscles and the structures better to see what the tone of the muscles are. Are they too high a tone where they're in a spasm, are held in contraction, or are they not able to actually contract at all because you've got them in a stretched position that they can't do what they need to do? So it's great as a resource, but it should not be your only treatment.
Sounds like a great topic for a separate webinar. Okay, next question came up in the chat, and then we'll jump back over to Q&A. My question for Dr. DiCecco is, and thanks for a great presentation. Any recommendations for home cardio exercise that is good/safe for lymphedema/weak pelvic floors? Rowing machines, treadmill, biking, anything like that.
So again, everyone starts on a different level. That are you very sedentary and don't do a lot of cardio, or are you running before you had your cancer or whatever diagnosis that led to lymphedema? The key with lymphedema is anytime you go to muscle soreness, you have inflammation, because that's the way your body naturally heals. So it's a very fine line that you have to walk between improving your cardio and strength and causing harm to your lymphedema. So you continue to push that line because there's so much research out there to show the stronger you are and the better cardiovascular fit you are, the better your lymphedema can be controlled and limit its issues or harm to you. So you want to find something that you can do safely, that's not causing muscle soreness, that's not going to hurt you. So a lot of times, depending on how low you're starting, it's just walking or walking in a pool. That a lot of times I'll tell patients, every time there's a commercial break, stop fast forwarding it with your video recorder type things, whatever, whether you have direct TV or whatever you use, get up and go walk for the commercial break, or at least stand in your chair and march in place if you aren't up to cardio speed. If you are, then find something that you enjoy doing and challenges you. For me personally, I have shows that I can only watch when I'm in the gym. If I want to know who killed who or who's dating who or whatever the show I'm watching, I try to flip between romance and murder mysteries. So I keep it, alive in there for me. But I won't watch those shows in any other room of my house. I only watch it when I'm in the gym. So it encourages me to go. So you have to find something you enjoy doing or are encouraged to do and that you can do safely that works for you. So it can be walking, it can be bike riding, it can be a rowing machine. As long as you're not harming yourself, then you should be okay. You just have to find what that is. And a lot of times your therapist can also help you. And there's a lot of great resources out there with the chair yoga, the Pilates, all kinds of stuff for lymphedema and cancer survivors. I even had my students at the university I work at, I made them this past term actually start going to some of these things to see what it is that patients go through so that they can refer. So there's a lot of great ones out there. They whipped my students behind on some of the Pilates ones. Chair Pilates got them.
Yeah. We also have just a quick plug there. We also have a Lymphy Strong fitness group.
Yes,
so
you
if
do.
you want to jump in, we can jump into, if you want to jump into that Facebook group, you don't have to post or click like, nobody has to know you're in there. But if you want to search using a keyword like Pilates or chair yoga, scuba, just about anything under the sun, I think, other members have asked, and, post a question if you have one. There's that resource as well. Next question. What is the buttermilk wash for infection? That was one of my questions. Well, not for me, but I had that same question.
So I don't usually recommend doing that. I prefer you just rinse with cool water. But for some, depending on what's causing the irritation, buttermilk is a very alkaline, so it can reduce the acid component in the region. But again, I would rather you use water or the wet wipes as opposed to buttermilk. But that is something that some patients have used when, especially they have an acidity component in the region. Typically I take that out, but I left that one in that for this one.
Okay, does the rowing machine address the pelvic floor muscles, or is it contraindicated, especially with combination urinary incontinence?
So technically, your pelvic floor and your transverse abdominis is the one that if you ever see someone that is really, 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 really fit and you see their pelvic bone, there's a little slug thing that comes out right at their pants line. That's the only time you see the transverse on a person, because it's underneath the other 3 sets of abdominals. But your transverse abdominis and your pelvic floor are your true core muscles. You have other layers on top of that, but those besides your heart are probably the 2 most important muscle groups in your body. So before you do any activity, your body is naturally, even moving your arm, your natural aspect is your pelvic floor and your transverse should contract to some degree to help protect the organs and the structures in your abdominal cavity. Unfortunately, for a lot of people, especially if you've ever had back pain, we have found that that symbiotic relationship that should be occurring is altered. It's dysfunctional. It's not occurring. Especially if you've had traumas, you've had surgeries, you have other things going on, that relationship is broken. So whenever you work out, you technically should do a Kegel, a transverse contraction to stabilize yourself and protect it to do it. So if you row correctly before you pull back, you should have done a Kegel with a transverse contraction at the same time. Then you do the contraction for the row machine. If you do that, then yes, it will build your pelvic floor. If you ignore your pelvic floor and you lift heavy weights, you do the rowing machine or other components where you increase your pressure in your abdomen and you don't have the pelvic floor to fight back, you can actually distend your pelvic floor and organs and make them weaker. So so it can, it's just you have to learn how to properly do it. And that is something also a pelvic floor therapist could help you do to figure out how to build that relationship back.
The human body is just so complicated.
Yes.
Wow. Okay. So this next one is, thank you. I'm overwhelmed by all the information you have provided. This webinar answered many questions I had. Wow. I'm ready to tackle this new challenge as I have recently been informed that I have genital lymphedema. This webinar was a gift.
Thank you. I'm glad.
Yeah. Thank you so much, Dr. DiCecco. I wanted to remind everyone we are recording this webinar, and it'll be up on the Lymphy Strong YouTube channel. So if you need to review it, play it back, go back and forth, write notes, it'll be up there, and just subscribe and you'll get an automated notification. But I really like how she said it was a gift, especially right here, right before the holidays.
Yes.
I couldn't agree more.
And I didn't have to wrap it.
And the last question that we have here is, what is a squatty potty?
So a squatty potty is something that came up, or someone on Shark Tank invented, that when you sit on the, sorry, my cat is knocking stuff off because I'm ignoring him. When you sit on a toilet, your knees should be just slightly up above your thighs. Okay, for most of us, that is the natural position you should be in for using the bathroom. The shorter person on a larger or higher toilet, often your knees are below your thighs, especially children. And so what that does is it throws off your pelvic floor, that they're trying to contract and hold you, and they can't relax to let you actually have a bowel movement. So someone invented what's called the squatty potty. You can Google it, that you put it in front of your toilet and your feet prop up on it. that, again, I don't do product endorsement, but most people have given it as gag gifts at Christmas time and other stuff. But you can simply use, none of us use telephone books anymore. So I always tell patients, find your old telephone book or one of your school books you don't use and put that in front of your toilet to raise your legs up, because you should be able to relax on the toilet. If you can't feel that you're relaxed, you're not relaxed, and your pelvic floor can't allow the bowel or bladder to empty as it should.
Right.
Yes, a yoga block, I
oh,
see that works great.
yeah.
It depends on how high or short you are, as to how much you need to lift up. And you can kind of play with it. See, are you able to have a better bowel movement with the yoga block? Are you better to have it with a smaller block or whatever component, to see how can you feel you're really able to relax on a toilet?
And this is our final questions. We are at an hour and a half. I know that you've been so gracious with your time here with us. The last question is, what is the transverse contraction?
So if you take your hands and you put them on your waist, you should find a very pointy part of your waist, right in the front of your pelvis. It should be a very sharp, pointy piece of bone. If you bring your fingers in about an inch and down about an inch, you should feel kind of a drop off, because you're now off of your rectus. You stepped off the rectus. If you laugh, if you try to pull your belly button in like you're trying to zip a pair of tight jeans because you just ate too much at Thanksgiving or about to eat too much in the holidays, you'll feel a little bit of a bump come into your fingers. That's the transverse muscle contracting. It's not a huge contraction because the muscle fibers run from your pelvis to pelvis. So if it did a big contraction, you'd fold in half and be nothing but a butt. So the muscle just tightens down and protects the region, but you don't want to hold your breath. You don't want to bear down. You just want to, like you're trying to pull your belly button back, you'll feel a little pump come out into your hands. And that is a transverse contraction. As you get stronger, you will feel a stronger punch. And hopefully this time next year, you'll all have the little pictures where you can see the slug line down the pelvis.
Wow. Okay, so we're going to wrap it up here. Just a quick reminder to everyone, none of this is medical advice. We're here to share information. Dr. DiCecco and I do not have a financial relationship. We're just friends in the lymphedema community. We got to talking and we said, hey, we should do a webinar and talk about the pelvic floor, because like I said, every time I see her speak, she's absolutely amazing. And I learned so much stuff. And this is an often overlooked, and quite frankly, in my opinion, it's not talked about enough. Whether it's because those of us who suffer from pelvic floor issues are shy or don't want to ask. But I think it's important that we have, patient champions like yourself that advocate and share information on these issues, because so many people are suffering in silence. And, it's painful. It's painful and it's isolating. And as you said before, there are some psychosocial components there. And so I want to thank you for all of your work and everything you do. And again, for agreeing to be on the channel with me. Do you have any final comments for the
Thank you for having me. And like I said, I did put my email in the chat. So feel free to email me if you have questions. And I hope you all have a very safe and happy holiday.
Thank you so much. Have a wonderful evening or morning or afternoon, wherever you are in the world. Thank you so much for attending, everyone. Appreciate it. Good night.